Okay, everybody, good morning. Let's get started. It's my great honor to moderate this session with Professor Olga Marinova. Okay, let's introduce the first speaker. First speaker is Magnus Sahintos. So his title is Experimental Pancreatitis, Accomplishments, Aspiration, and Barriers. Okay, let's welcome Professor Magnus.
Thank you, thank you, thank you, thank you. So it's hard to be the first one after the break because everybody's out from the room. But let's. So this is an educational session where it's not so much about new data, but my presentation followed by Sohail Hussein's presentations. We focus on animal models and how we could utilize them in our research. And I've seen many great presentations yesterday, and I noticed that everybody still uses Cerulean model for everything. It looks like that's the only model. And even for Cerulean, as you will hear in the next presentation, they use a variety of different protocols. So I'm going to talk about mostly accomplishments, and a little bit about aspirations. So I will focus on genetic models. I'm trying to plug these models so people start using them in their research. And so human pancreatitis genetics is really complicated. So we organized the different genes and variants, which were identified over the years into pathological pathways. And the two pathways which I'm going to focus on today are the trypsin-dependent pathway, which is clinically the most commonly identified, and the misfolding-dependent pathway, which is very interesting. And we already had a lot of talks yesterday. Mark Lowe's lecture was about the misfolding-dependent pathway. So I will describe what kind of animal models people developed, the past 10 years. So focus on trypsin-dependent mouse models, which target trypsinogen activation, models of SPINK1 inhibitor deficiency, and models of chymotrypsin deficiency. For the misfolding models, CPA-related, lipase-related, and these were discussed yesterday to some extent, and trypsinogen misfolding related, which is an interesting subgroup. I'm probably not going to have time, and then please stop me if I run out of time, to cover all of this, but I wanted them to include in the slides, so if they post them online, you can use this as a reference. So these are the genes in the trypsin-dependent pathway, and then the explanation is underneath. These are either trypsinogen genes, there's a trypsin inhibitor, and various chymotrypsins. What kind of models do we have to model a trypsin-dependent pancreatitis? So most of the models focused on increasing trypsinogen activation, autoactivation more specifically, by introducing gain-of-function mutations into the trypsinogen. So my group used the native mouse cationic trypsinogen for these models, which we typically called isoform T7 in our papers. There's a newer gene name, which is called PRSS3B, and all our models were knock-in models. And we did a whole bunch of these models, and I'm showing 3 of these, where we introduce different mutations and you get different levels of activation. And this is a test tube experiment with purified proteins, but these are like 3 mutations which we put in the mouse, but they all give you elevated trypsin levels, starting from a 5-fold elevation up to 50-fold elevation. And then you get 2 types of phenotypes with these mice. In one with lower trypsin activation, you get no spontaneous disease, but you get much more severe cerulean-induced acute pancreatitis, and you get progression from AP to chronic pancreatitis. And if you have more trypsin activation, you get spontaneous disease in the mice, starting with AP and a rapid progression to chronic pancreatitis. And I listed some of the models. So again, these models are available to anyone who's interested to use them in their research. Just to show you a quick example. So this is one of our first and favorite model, where due to the mutation and the increased trypsin activation, mice develop acute pancreatitis at the age of 3 weeks, and by 4 weeks, 5 weeks, they progress to early chronic, and then by 2 to 3 months, late chronic pancreatitis with almost complete destruction of the pancreas. Many of these models, in fact, all of these models do great. They breed well, they're very easy to handle, easy to maintain, which is a big plus. A second set of mice was developed by Bo and G's laboratory, and I'm listing all the papers he published over the years. And Bo and G's laboratory mostly focused on human transgenic models where they introduced the human cationic trypsinogen, sometimes combined with the human anionic trypsinogen into mice in various combinations. And he showed very similar phenotypes, either no spontaneous disease, but high sensitivity to experimental pancreatitis, or in some models, spontaneous pancreatitis. Advantage of these models he developed, which are also available from his laboratory, is that if you have anything targeting specifically human trypsinogens, then these are the models you need to use to study. Very robust phenotypes. It's important to note that the two sets of models, the mouse cationic trypsinogen and the human cationic trypsinogen models, phenotypically are very, very similar. There was a lot of work put into the SPINK1 deficiency models. So SPINK1, as we heard in the previous presentation, has different loss of function mutations in humans. And in mice, we typically model this by just deleting the SPINK1 gene and not really by introducing the mutations, although there have been some attempts. In early work, it dates back to 2005, Masaki Omuraya made the first knockout. But unfortunately, the homozygous knockout is lethal, so you can't really study that. And the heterozygous knockout doesn't really do too much. And then Roger Little's laboratory did a whole series of transgenic overexpression demonstrating protection. I think some of these strains may have been lost, since that time, but there are newer strains which we can use. We developed a new knockout strain, and we focused on trypsin-dependent pancreatitis, because the early models did not test these strains in a trypsin-dependent setting. And what these histology slides show you, that if you take a trypsin mutant model, which is the middle section, the model develops spontaneous pancreatitis by 6 months. But if you take away half of the trypsin inhibitor, then you see spontaneous pancreatitis by 4 weeks. So in the setting of a trypsin-dependent disease, the lack of the trypsin inhibitor accelerates pancreatitis. So what about natural SPINK1 mutations? The N34S mutation, which is the most common, there's no models so far. We don't really understand the mechanism, as we discussed a few minutes ago. The group in Shanghai published the introns 3 splice variant. They published 2 papers on this, but this model remains poorly characterized, and it seems from the publications and personal discussions that it may have very variable phenotype for reasons that are not clear. So if you want to utilize SPINK1 strains, still the best option is a simple knockout heterozygous strain, which you can combine with your gene of interest. So how about chymotrypsin deficiency? Again, humans carry mutations in chymotrypsin genes, mostly chymotrypsin C, and these are loss of function mutations. And again, in the mouse, we model this by deleting chymotrypsin, because that's as simple as there's no chymotrypsin mutant mouse models at this point. Now, humans express 4 chymotrypsins called B1, B2, C, and chymotrypsin-like enzyme in the pancreas. The B1B is a duplicated locus. The mouse does not have that. It expresses a single isoform, and also CTRC and CTRL. However, in the laboratory strain, which we often use, the Black 6 strain, as we showed, there's no CTRC because it's naturally deficient. And chymotrypsin-like protease doesn't really play a role, even if you knock it out. So there are models available for this. what works in the mouse best is the chymotrypsin B knockout or combined with the chymotrypsin-like protease knockout. And we published 2 papers on this. These have very robust phenotypes. And the very nice thing about them, you're not manipulating the trypsin locus. You're manipulating a completely different chromosome. And even though there's no spontaneous disease, these develop very severe cerulean-induced acute pancreatitis, and they progress readily to chronic pancreatitis. Even the wild-type mice, recover quickly after cerulean challenge. So I highly recommend these strains if you don't want to touch, the trypsinogen chromosome, which is sometimes difficult to manipulate because there's a whole lot of other genes are on that chromosome which are important for pancreatitis. So a big advantage of these models I quickly ran through is that obviously you can use them for preclinical studies and test preclinical trypsin inhibition in these models. So there's been 2 attempts made so far. One is with dabigatran, which is an anticoagulant, FDA-approved anticoagulant, where first Bo and G's laboratory showed that it's efficacious in trypsin-dependent pancreatitis, and we also demonstrated that in a more detailed study. And then the second set of studies which are ongoing, some mainly in my laboratory and also in Shanghai, Wenbin Zhu has done very nice studies on this, is gene therapy using adeno-associated virus and the SPINK1 inhibitor. So this was our dabigatran study from 2022, and it would be very nice to think about this if any clinical follow-up in terms of a clinical trial is feasible to see if dabigatran would prevent recurrent attacks. Was shown here that in a cerulean-induced atrophy model, dabigatran treatment partially or fully protects the pancreas against damage. And again, similar results have been described by Bo and G's group. So the Shanghai group published the first paper on the SPINK1 gene therapy, and where they showed some efficacy, but they struggled with expression. So together with Gergő Berke, who just gave a presentation, we tweaked the SPIN construct, and we achieved a 10-fold increased expression by introducing mini introns in various places. And then we use this to make adenovirus. And currently these studies are underway to demonstrate, proof of concept of efficacy. So I went through some of the accomplishment for the trypsin-dependent mouse models, and I'm going to quickly just breeze through the slides for the misfolding dependence. But before I do that, I'd like to highlight 2 things. One is the aspirations. So all these models, the aspiration is that you're going to start using them in various settings together with the cerulean-induced models, and they more and more will be used for preclinical studies. And the barriers, I mean, this is a very interesting time, we believe, because funding barriers are clearly is a major hurdle these days. And I'm going to stop just to show you the misfolding dependent models and without explaining them too much, because Mark Lowe explained them very well. So these involve the carboxypeptidase A1 model, which we developed first, and which is a chronic progressive spontaneous pancreatitis model. Various lipase-related models, mostly developed by Mark Lowe, or in collaboration with Anders Molven in some cases, but also the Shanghai group developed a lipase-related mouse model. And more recently, we developed a trypsinogen misfolding model. It's not commonly understood that in some cases trypsinogen doesn't work as through trypsin activity, but just works as any other protein which happens to misfold and cause pancreatitis. And if you look at this slide, on the right side, we actually cross this strain with the CPA strain just to demonstrate that if you increase misfolding proteins, you get a much more accelerated phenotype. And again, this is the generic, very similar phenotype across all the different strains of the misfolding mutants. And some nuances were discussed in yesterday's lecture with the cell MODI strain versus the lipase or the CPS strain, but by and large, this is very common. And I leave you with the same slide I showed you before, which shows all the accomplishments, and these are readily available, some of our aspirations, and one major barrier. Thank you for your attention.
Okay, thank you, Magnus. Thank you so much for giving us such a comprehensive, wonderful presentation. Let's discuss at the end of this session. Okay, thank you again.
Yeah, next presenter is Dr. Hussein. Yeah, and it will be, the presentation will be about the data harmonization and SOPs, and starting with the hotly debated cerulean models. Yeah.
Thank you very much for that introduction. Good morning, everyone. I've been tasked to really talk about something that has been around for a long time and with important nuance. And at this point, I would just ask each of you if you can scan this QR code or go to the slido.com. I'll give you a couple of seconds. And as you are doing this, I'll tell you about a workhorse in the field that you've heard about over the last 3 days, cerulean pancreatitis. I'll make the pitch, though, of the benefits as a field for data harmonization with this particular model as a standard operating procedure. And I hope you'll see that even though it's hotly debated, there's an opportunity for us to leapfrog. And with that, let's launch into this poll. Hopefully this works. Okay, how many of you have used cerulean in your research at some point in your career? We'll give it maybe 3 to 5 more seconds, so please act fast. And I thought it was going to be over 50%, and clearly we can see that it's over 2/3. And your responses show how pervasive this model is in pancreatology. And so thanks for doing that. We'll have one more poll. But first, I wanted to give you a historical background on the basics of cerulean hyperstimulation pancreatitis. Cerulean is a decapeptide CCK analog, as shown on the right, that is, however, more bioactive and stable. It was first isolated from the Australian green tree frog, and at hyperstimulation dosing, cerulean induces pancreatitis by binding low-affinity CCK receptors on pancreatic acinar cells. And the bottom graph is of PubMed publications using the search term cerulean pancreatitis. And as shown by the leftmost arrow, in vivo cerulean was first reported in 1977 in rodents, starting with rats, and subsequently in other animals, as described here, dogs, hamsters, rabbits, more recently ferrets, and a paper in zebrafish. And since 1985, as shown in the arrow further to the right, mice in vivo studies have dominated. And cerulean has most often been used to induce acute pancreatitis. It is highly reproducible. It is a mild form of AP. And the advantage is that supramaximal concentrations of cerulean given ex vivo in pancreatic acinar cells can mimic the acute acinar injury that's seen in vivo. So it's a really helpful correlate for translation. There are, however, controversies with cerulean AP, including its relevance to clinical pancreatitis etiologies, the concern that CCK receptors are either absent or lowly expressed in human acinar cells. But the argument is that cerulean AP is a surrogate of secretagogue-induced pancreatitis, and there are a couple of clinical correlates shown here with scorpion toxins or organophosphate toxicity. But most importantly, the downstream cascade of pathological events mimic other etiologies of AP. There are combination protocols with cerulean. You've heard of the genetic drivers, LPS, enterokinase medications, partial duct ligation. Cerulean's used for CP models and PDAC. However, by itself, in the setting of AP, it is most highly published. And so here's the second online question for you as an audience. How many total injections do you typically give for cerulean AP? I know that 68% of you should be able to answer this. And whether it's 1 or more days. And the moderators are also welcome to do it if you want. And it will take another 2 or 3 seconds. Hopefully this is more engaging. We'll wake up. So it seems like 7 is winning, but as you can see, there's a point I think that's being made here, which is the central issue of my talk, that even in the same room, our cerulean AP protocols differ. And so thank you for participating in this poll. So there's no established or collectively agreed upon SOP or standard operating procedure for cerulean AP. Listed here are some of the variable parameters to protocols in published reports. And they include, as discussed, injection frequency, the number of days of induction, dosing, the mouse strain that's used, which may have an effect on the outcome, the age of the mice, fasting status, analgesia given, if any, measurement time points, assay parameters, including what the primary versus secondary endpoints are, differences in various grading severity scores, and different statements about sample size estimates, variable reporting standards, including for metadata, which is increasingly becoming more important, and even variability in the timing of an experimental intervention. Well, I believe that this is an opportunity for data harmonization, which is defined as the practice of combining different data sets to maximize their comparability or compatibility. While data can be harmonized retrospectively, it is ideal to strategize a harmonization schema prospectively. And the first step is through generating SOPs that we share, which are simply written instructions for doing a specific task in a certain way. And I wanted to illustrate this in a cartoon of 3 labs that are generating data with diverse protocols. Each data set can only be separately evaluated. With an SOP, however, labs can now compare their data across studies. And in the future, with some effort, there's the potential to pool raw or normalized data for boosting statistical power, which makes for happy campers. Well, there are many other tangible benefits of SOPs as a field. In addition to harmonizing data, it improves reproducibility, rigor. It provides a checklist for researchers, editors, and reviewers. It facilitates engagement for cross-disciplinary collaborators, industry partners, and journal editors. It can boost, as a result, impact for the field, build greater confidence for section reviewers to evaluate grants, gain greater trust among investors in the field. And part of the reason why I thought this talk was important was because many of us are now being approached by potential investors and being asked about where the field collectively stands on these questions. They can also stimulate the pipeline in experimental pancreatitis because there will be fewer struggles with methodology as a result for early career investigators. Well, there are lessons from other fields for leapfrogging with shared SOPs. I've listed just a few, including the Human Genome Project, which had strict SOPs for 20 centers across 6 charter countries. The current explosion of real-world data, which relies upon common data models. Zebrafish community has SOPs that are shared globally. The long-authored autophagy guidelines are now in their 4th edition, and they cut across disciplines and provide unified definitions. They're shining examples in oncology, including in pancreatic cancer GEMS, and recently with the US Clinical Pancreatitis Consortium SOPs. Well, we can learn from them for what worked or didn't. An SOP must provide value, not burden, such that we make the pancreatic juice worth the squeeze, if you don't mind the cliche. The key principles are to avoid stifling innovation by allowing protocol deviations to be documented, by avoiding becoming dogmatic, by acknowledging the strengths and limitations of the SOP. It won't be perfect, but is it usable? And by periodically reassessing the shared SOP, whether after 5 years or more, and by asking questions such as, was the SOP useful for interoperability and data harmonization? And to make this a collective effort. Well, this collective effort is taking shape as an APA-led initiative for a consensus cerulean AP SOP to be launched next year. I will serve as the chair, and co-chair will be Dr. Jamie Solomon. We hope to make this a collective effort with a call for applicants for a small but mighty task force. And our goal is to come up with recommendations for an induction protocol, assay parameters, endpoints, data interpretations, sample size estimates, arrive-aligned reporting criteria, and a QC workflow for data submission to open source. And this, we hope, will be published as a useful document in our journal, The Pancreas, to provide a framework for future SOPs in experimental pancreatitis. We'd like to study SOPs from related disciplines. We'd like to recruit medical librarians to optimally use AI search tools and consensus criteria. And most importantly, we welcome member input. To envision the value of this collective, here's a hypothetical box summary of the consensus cerulean AP and what it could look like. This is hypothetical. This is not the final. We haven't even started. But if I had to do it, if you asked me just on the spot, this is what it could look like. And imagine how useful that would be. In just ending, I wanted to also make the pitch that a shared SOP is also an opportunity to get ahead of the curve. While the 3 R's of animal research are not new to reduce, refine, replace animal testing, recent acts of Congress and roadmaps and initiatives at the FDA and NIH are now highly advocating the use of innovative human-based new approach methods, or NAMs, to reduce animal use. And we need to be smart and strategize the judicious use of animals by employing SOPs for the validation of these NAMs. And so the result is stronger science and reusability. An SOP for cerulean AP is just one part in this fabric of a larger effort to generate a comprehensive toolkit to advance pancreatitis discoveries. I believe that our field should have RC2s, NIH-funded resources that other fields such as liver and so on have. And we need to start by this process that begins with in silico studies and goes all the way to clinical trial phases. So in summary, cerulean AP is the most common animal model of AP. There's a challenge to harmonize data with the current versions, and thus there is an opportunity to establish a shared SOP. It is a value proposition for experimental pancreatitis to leapfrog and to be ahead of the curve. An SOP of this type could be one as a start among many others. And the overall goal is to further elevate the impact in the field and to importantly stimulate the pipeline. So thank you for your attention.
Thank you.
Okay, let's welcome the third speaker, Anna Gnoy. Her title is Tools for Basic Exocrine Research. We can borrow from our islet neighbors. Please.
Thank you. Well, good morning, everyone. Thank you to the organisers for the opportunity to join you here for APA, and also for humouring me with the chance to tell you about our endocrine compartment in the pancreas. So we're going to have a little bit of a shift of gear now. You can see here I've tried to bring a little humour into my talk with a ChatGPT derived picture of the little exocrine cells reaching out to the endocrine compartment asking for a cup of sugar, because we are good neighbours. Right, so my work is really on pancreatic islet cell dysfunction in diabetes, and I think it's fair to say we can accept the fact that you don't become somebody with diabetes unless you have a form of islet cell dysfunction. But how you reach that islet cell dysfunction can be very different. There are lots of different causes, both genetic and environmental, and then there are lots of different ways that you can lose your islet and beta cell mass. There are developmental defects, there's beta cell loss, and of course there are dysfunctional components of the machinery that couples glucose metabolism to insulin secretion. And really interrogating all of these different mechanisms helps us to understand diabetes heterogeneity. And the way that I do that is that I use human genetics. I focus on causal variants that are responsible for monogenic varieties of diabetes, or common genetic variation in the population that increases your risk of developing type 1 or type 2 diabetes, but always starting from that human genetic anchor. So I think we've already heard a little bit at this meeting about the fact that over the last 20 years or so, as we've had increased access to human primary islet tissue, we've really begun to appreciate that there are substantial differences in the composition and workings of a rodent and a human islet. And this is really important as we try to translate human genetic discoveries into human mechanisms of diabetes. We see differences in their architecture, in the a number of ion channels and glucose transporters that are present, in how cell cycle is controlled, and even and importantly during pancreatic development, the roles of transcription factors are very different. So this really speaks to the need to have good human models if we're going to be able to move from those genetic discoveries to understanding what's happening at the level of the human islet. So I'm very much inspired by the work of the late Sidney Brenner. Many of you will know he won the Nobel Prize for his work primarily on a model organism called C. elegans. But he was very, very forward-thinking in his understanding of where we were going post the Human Genome Project and the wealth of data that was going to be amassed on humans. And he started to think that really we didn't need another model organism. Actually, humans were the model organism. So over the last few years, I think work in the field of the endocrine pancreas has really transformed on the basis of two key findings. One, and you heard a little bit about this from Teresa on Wednesday, there is now increased access to human islet tissue. And there is also finally the availability of authentic human beta cell models. This was a holy grail. We'd been working with rat and rodent in beta cell models for many years, but now we finally, thanks to the works of Raphael Schaafman and colleagues, have human authentic models. And I think this also speaks to another point that I'd like to echo today, because I think it's the feeling of this symposium around the fact that progress in science really depends on new technologies and techniques, new discoveries and new ideas, and in that order. And again, this comes from Sydney Bremer. So we see these transitions in our ability to shift the needle when we have new technologies. So today, as I take you through some vignettes from the work in the endocrine field, I'm really going to tell you how we've integrated human islets, human beta cell models with state-of-the-art genome editing, high-throughput screening, and of course, touching on machine learning and artificial intelligence. And I want you to take away from this, and I also want to echo what Suhail has just said, the importance of international collaboration, data sharing, data standardization, and increased access to data. So I'm going to take you through this by giving you some examples of how we can learn about these three major ways that we can lose our pancreatic beta cell mass. And we're going to start by an example of learning about the developmental defects in type 2 diabetes. And the starting point of this story is the discovery back in 2016 in a large exome sequencing project that we did that was drawn from 5 different ancestries of a variant in the PAX4 transcription factor that's unique to the East Asian population. So we started to think about how this causal coding variant could be increasing risk for diabetes. It's present in about 20% of East Asians who develop diabetes under the age of 45. Now, we know from mice that this transcription factor is critical for beta cell development. And if you knock out this transcription factor in a mouse, homozygous null mice will die by day 3. But I've already told you that the development of the human and the mouse pancreas are very different. So the foundational work that's been done in mouse models, where we know that PAX4 works in a reciprocal manner with another transcription factor called ARX to determine the cell fate, whether that endocrine progenitor cell becomes an insulin-producing beta cell or a glucagon-producing alpha cell. Can we translate that knowledge from the mouse directly to humans? So I was part of a collaborative grant and a paper working with colleagues from Singapore, where we tried to address the question of what does this variant do in the PAX4 gene in humans, and how does it relate to increased diabetes risk? And we tackled this using human models and using a variety of different human models. We first of all recruited around 200 people who were non-diabetic who carried the variant, and we performed oral glucose tolerance tests on them to demonstrate that the carriers of the variant had reduced beta cell function. We then made stem cells from carriers of the variant. We used CRISPR to correct the variant. We used in vitro differentiation protocols to make pancreatic beta cells in a dish. And we then used multiomics to profile those cells. And we could demonstrate that there was a failure of those cells to make it all the way to beta cells. And they ended up being positive for both insulin and glucagon. And you can see that here in the immunofluorescence. We then used another beta cell model derived from the human fetal pancreas to show that if you ablate the cells of the transcription factor, they are unable to respond to glucose stimulation effectively. So using a suite of different models and capitalizing on human data, we could demonstrate that there was a mechanism here that this variant in PAX4 reduced the ability to make authentic beta cells in humans. But what about a human knockout? Wouldn't it be amazing if we could find somebody in the world who didn't have any PAX4? That would be the equivalent experiment to the mouse, a human knockout. So we collaborated with colleagues in Exeter who've assembled a really large database of children and adults with presumed monogenic diabetes, and we performed whole genome sequencing. So we had around 4,500 probands with undiagnosed monogenic diabetes in whom all known genetic etiologies had been excluded. We did whole genome sequencing, and then we looked specifically for homozygous knockout in a gene. We identified 2 children with transient neonatal diabetes who had loss of function mutations in the PAX4 gene. These are human knockouts. These are an amazing opportunity to understand what total loss of this transcription factor does in humans. We were able to show through careful clinical characterization and also functional studies that if you lose the entire transcription factor in humans, you still make a pancreatic beta cell. You do survive, you can secrete insulin, but you have bihormonal cells. They are positive for both insulin and glucagon. So this is very different to the mouse situation. The mice die, humans don't, they survive, they have a relapsing and remitting phenotype throughout life. So that's an example of how we've combined clinical phenotyping, human genetic data, stem cell models, genome editing to really deliver mechanisms for beta cell developmental defects. What about how can we get to mechanisms of beta cell loss using authentic models? Well, some time ago, we decided that things were going too slow, and we really wanted to accelerate our efforts to understand what all the genes in the genome did to our ability to make the hormone insulin. So we set about to do a genome-wide screen. We thought, what if we can take all 18,000 genes, knock them out in a human beta cell, and get a functional readout of how much insulin those cells produce? So we did this using a CRISPR loss of function screen. This was a Herculean task. This is Antia, a student from my lab, and it shows the 4 months it took her to grow up this really difficult to work with cell line, but it's so authentic, it's so like a primary beta cell, it's worth it. She spent 4 months making 700 million cells and then deploying the genome-wide screen. We identified 580 genes that robustly influence how much insulin is made in the pancreatic beta cell. That's 580 genes that we now know about that are important for making this hormone. You can go and look up this data. We've made it all publicly available. You can go to the Common Metabolic Disease Knowledge Portal, scan this QR code, it'll take you directly to it, and you can look up any gene to see whether or not losing it in a pancreatic beta cell affects insulin production. We can then take that data, we can integrate it with genetic data, and we can identify causal variants and transcripts at GWAS signals. We found 20 that were overlapping between our genetic data and our screen. And then we can study these, particularly those that we knew nothing about before this effort. One gene that came out in our screen was calcoco2, never been looked at in a pancreatic beta cell, but we now know that this is a really important protein that governs granule homeostasis, and it works through autophagy and mitophagy. And if we look at that list of 580 genes that we identified, we can see an enrichment for both autophagy and mitochondrial dysfunction. So finally, what about dysfunctional beta cells? Well, some of you in the room will know about monogenic forms of diabetes, and one of the most common genetic etiologies there are defects in the enzyme glucokinase. This is the key step in glycolysis in the beta cell that links glucose metabolism to insulin release. Now, if you have a loss of function heterozygous mutation in glucokinase, this is a really good genetic diagnosis and a really good explanation for your diabetes, because you can come off insulin treatment and you can manage your diabetes with diet alone, because the phenotype is stable fasting hyperglycemia, and your risk of diabetes complications are really rare. So wouldn't it be wonderful if every time you ordered a genetic test for somebody because you suspected they had glucokinase monogenic diabetes, you didn't get a genetic test that came back with a variant of unknown clinical significance? What if we could correctly annotate every single glucokinase variant that you could ever discover on a genetic test? Well, that is our task at the moment. We're working with others to deliver maps of variant activity for all monogenic diabetes genes. Here's one example of a yeast functional complementation assay where we took close to 10,000 different variants in the glucokinase gene and we assayed them all in a single assay, and we can now correctly classify just shy of 80% of all variants. So if you order a genetic test, you can use these data to help interpret the significance clinically of that variant. We don't think 80% is good enough, so working with a bioengineer, Polly Fordyce from Stanford, we're now moving our assay onto a microfluidic device that will allow us to measure enzyme function at scale. We'll be able to do hundreds and hundreds and hundreds of different proteins on a single array and get detailed characterization that will allow us to classify these variants as gain of function, loss of function, and to deliver precise genetic diagnoses. So I know this has been a whistle-blown tour of the world of endocrine research, but what I hope I've done is whet your appetite about the opportunities that we have in this amazing time that we're living in for human genetic and human omic research. We can integrate human genetics for any disease that we're interested in, any trait that we're interested in, and we can couple this with authentic models, and we can dissect relevant mechanisms that are appropriate for understanding human disease biology. I hope I've encouraged you also to embrace efforts to do things at scale and genome-wide so that you can accelerate your discoveries. And finally, I'd like to reinforce the fact that none of the work that I do would be possible without collaboration and interdisciplinary science. Working with people with diverse skill sets and diverse interests are absolutely key. So let me finish by thanking my team back at Stanford and also drawing your attention to two resources. PancBase, which you're going to hear a little bit more about later today from my colleague Carl Galton at UCSD. He'll tell you about a resource for collating human pancreas data, which we really hope our exocrine colleagues will embrace and look into. And I'd also encourage you to look at the Atlas of Variant Effects, which is an effort to catalog the effects of all variants and all genes so that we can facilitate clinical interpretation. Thank you to my funders and happy to join the panel for questions.
Okay, thank you, Alan. Thank you so much for your excellent research report. Okay. Okay, let's start the discussion.
We can start the discussion, and any questions, please.
Good morning. Vijay Singh from Mayo Clinic, Arizona. Thank you for the excellent talks. My question, or rather thoughts, are relevant to Suhail's proposition for the standard operating protocol thing for cerulean. So I've worked with cerulean for about 27 years now. And there are significant barriers I would like to discuss and inform that should be incorporated when we start thinking of standard operating protocols. First, and you can note this down, manufacturer, batch-to-batch variation, goal of the study, the species, the route, and the stability. So there is a lot of variation in cerulean itself as it comes. When I started in '98 studying this, the one manufacturer for cerulean was Research Plus Incorporated. Research Plus doesn't make it anymore. Now, then came MP Biomedical, the Sigma cerulean did not work, then came Bachem. Bachem itself has various batches of cerulean, some of which work, some don't, some of which are aquastable, some of which are not at a high concentration. So there is a lot of variation which requires individualization with that batch of cerulean to make sure that it reproduces what a lab's own track record has been in the past. So that's one, manufacturer and supplier, batch. Then comes the goal, what do we really want to do over here with cerulean? If I just want to show that, see, one injection of something could elicit an amylase increase, we'll do it. But if I want to show this is the local inflammation that I can induce with cerulean, I may need 3 or 4. If I want to show that if I increase the number of injections, now I have more lymphocytic infiltrates and not just neutrophilic infiltrates, then I may go up to 8 hours. Now, if I want to induce lipotoxicity later on top of the cerulean, then I may go up to 12 hours for 2 days, or put an Alzit pump and infuse it for a long time. So the variations, and I may do that in a black mouse, different from a lean mouse than compared to an obese mouse. So there are so many variations, the strain of mice, whether you're doing it in a rat, whether you're doing it with a jugular vein infusion versus a tail vein injection versus a subcutaneous versus an IP. So the variations that need to be individualized for the experiment require a lot of thought by the PI who is engineering the experiment to think, what is the endpoint that I want to show over here using this model? So standard operating protocol, therefore, one set can actually be a very dangerous thing if the reviewer who's sitting there says, hey, you didn't follow the standard operating protocol, let me reject you. So a lot of experience is required in experimental design, individualization is required, corrections from batch to batch variation are required. A lot of things are required to optimize the cerulean to fit what the goal of the experiment is. And so we cannot take a standard operating protocol as being one that is universally applicable by everybody across the board. The supplier in India may be very different from the supplier here versus somewhere else. I don't even know who those suppliers are. So there are a lot of variations there.
And thank you. I would like to add this suggestion. The cerulean is very critical. And first, I would like to thank you very much for all of your excellent presentation and sharing your experience and raise critical questions. Yeah. This standardization is very critical. Cerulean itself as a chemical is very quickly can be degraded if a temperature is changed. Yeah. And also purity from different companies. Absolutely agree. Yeah, and dosage and combination and different combination before and after pre-treatment or a combination in alcohol. Some people use 1 microgram, another one 5, another one like acute is a 50, or huge difference if people use 100, and you start to compare the data and you cannot repeat it because you are not sure if it was correct dose or so. But additionally, I would like my personal experience and from our lab, the animals. The animals are extremely critical, and yes, it's a different type of mouse strains. It's one thing. Another one, I also pay attention in the table, starvation. Yeah, if you have a rat model or mouse model, starvation can affect very dramatically on your data. For example, we need to know very well biology of the animals, like how they often they eat. For example, if you put on starvation rats or mice, rats can survive very well, and the stimulation from this starvation absolutely different than in mice, because mice they have much shorter cycles, and if you keep mice before starting your experiment overnight for starving them, yeah, it's a very strong activation of autophagy. We checked it because we work on this pathway. And yes, it really depends on the experiment if you really needed the starvation. But if not, we need to remember that the starvation itself can stimulate other mechanisms which can influence on your responses as well.
Thank you, Olga. Just in the interest of time, I think we only have a few minutes, and I see many questioners here.
Fine.
I'll just make a very brief comment. This is why we want to take a whole year to discuss this. The devil is in the details. We certainly don't want to stifle anyone's ability to do something, but at the same time, you and I are talking because we're on the inside. But what the outside world sees is that when you don't have a standard operating protocol, they don't know how to start. They don't know how to really be inside when they're on the outside.
Pancreapedia has a very good directions of how to use cerulean for a beginner. So if you can refer them to there, maybe that's.
Let's discuss offline, but we have a year.
Next one, please. Yeah, sorry.
So yes, Rishi Mukherjee from Liverpool. Sohail, I'm just building on the last speaker's comments, but this is specifically related to the cerulean pancreatitis SOP. I think it's great work. I think it's been necessary for a long time in terms of harmonization and standard protocols. What I would ask, so there are 3 key points. One is that the severity, so the number of injections that you put up on your slide was sort of in correlation with the variety of severities in terms of the human condition that are assessed. So that's a key thing that needs to be standardized. The other thing I would say is timing of intervention. So these models is in terms of pharmacological development, we need to understand that a large number of the cerulean pancreatitis models have been used to assess novel potential compounds. So whether those are given in terms of prior to injections or during injections is also very important to establish. And the final thing is a question. So I do have a question. So I apologize for the previous point. The question is, have you considered AIML approaches to actually standardize the SOPs across the board that are being developed so that it can set up an iterative process? So cerulean pancreatitis as a model won't be static in time. We may have further developments, and there may be other groups or other recommendations or meetings that will modify those models, or somebody suggests to have a new standardized procedure. So is there consideration of a platform so that we can have an iterative process to update things?
Short answer is yes. And
Great.
thank you for the comment and the question. We certainly want
Next one,
mechanisms.
please.
Yeah, my name is Huamin Wang. I'm a pathologist from MD Anderson. I want to just kind of continue the 2 previous comments. I think, we also need to come up with a standard histology, evaluation in terms of severity, the grading of the pancreatitis, grading of the chronic pancreatitis, the inflammatory subtypes. I think those are very critical when you study animal models. On the histology level, we need to have a standardized, a grading scheme, which can be used by all the investigators on the mouse models. Thank you.
So that was my comment, and I think it applies beyond cerulean model. So, Miklos just showed a bunch of data where they really focus on measuring trypsinogens and things like that, which we don't often see in the cerulean model, for example. And so a standardized histological assessment approach as across all endpoints. And one thing that I wanted to suggest that I've seen in other fields is oftentimes when we say we're doing the same protocol across labs, and to Vijay's point, within labs, you get different responses. So in the pain field, there was a huge study where they had several different labs in different locations, order the same mice, order the same reagents, follow the exact same protocol, and really look at the reproducibility and reliability across and different endpoints. And I think that's also something that could potentially be considered once we have that foundational SOP.
This is very true. When we developed the first trypsin model, we had no idea what we were looking at because all the reference we had was the cerulean model. So yeah, readout standardization is a biggie.
Hi, Minoti Apte from Sydney. I really enjoyed all the presentations and thank you for bringing this topic together. But I'm going to be a bit more provocative and talk about cerulean itself. I mean, cerulean does not have a human counterpart. Taking cues from Anna's talk about authentically human models, I mean, really, why waste so much time on cerulean pancreatitis? Because humans do not get cerulean pancreatitis. So should we divert our effects more to things like alcohol and smoking-related pancreatitis, where you don't have those variations with cerulean? Alcohol is alcohol, it's very standardized, and maybe we should, maybe in addition to the cerulean SOP, but use the alcohol and smoking and those models that are immediately relevant to the human situation. So I'm sorry if I'm being provocative. We were dragged kicking and screaming into the cerulean model last year because of our the work we're doing with Steve and Aurelia and all that, but we still maintain that we should do an alcohol model with a trigger that's relevant to humans. And that can be standardized.
May I just make the comment that your points are very well taken. If you can find something that's as reproducible as a cerulean model, then I think we'll all embrace it. The question we have to ask is, how do we get larger stakeholders into our group such that they can reproduce these models easily? And cerulean, I thought, was a start, and since it's so highly used.
Hi, my comment is not so much about standardization, but more directed toward Professor Santoth, who gave a very, I think, fair and balanced and thorough review of animal models. But, and I want to touch on something previous questioners also touched on, but I have slightly different thrust to deliver, which is, it almost seems as if animal models and human pancreatitis are existing in completely different worlds. When we look at animal models, we're judging severity by how destroyed the pancreas is and how many immune cells we can count in there. Whereas with humans, it's purely based on how many organ systems are failing during the course of pancreatitis in the hospital. So just simply to make that point, I guess a question for you might be, are we planning to evolve our animal models in such a way that we start to address the human version of severity?
I think Vijay can answer this.
The fundamental conceptual flaw in cerulean model and its human application is that we take an initiator, which is cerulean, which starts cerulean signaling in asthma cells, and take that initiator and we want to link it to an outcome of organ failure in human disease, which is why patients stay in the hospital. Initiation does not equal outcomes. For any disease, most diseases, unless it's a monogenic disease, initiation does not equal outcomes. COVID-19, same virus strain could be mild and lethal. There was a modifier that changes outcomes. Same with cerulean. So coming to answer Dr. Waldron's point, it is a modifier. What we find as clinically relevant is you put fat on top of that insult, you put a modifier, and you induce organ failure. All the outcomes relevant come out. So again, what I'm trying to come to is that what is the purpose of the model? I think you cannot put a standard operating protocol. If I want to do a dose response curve and see what is the difference between 1 microgram, 3 micrograms, 5, 10, 15, 30, and over time, I will test that in a strain and see what is the dose response. It cannot be a standard operating protocol. So to give the investigator the freedom to achieve what they really want to study, we cannot cubbyhole them.
Thank you very much. Yeah, we close our session. Yeah, thank you.
Good morning. We're running a little bit behind, and I think we should get started. Welcome to the next session, Breakthrough Clinical Trials, Clinical Management, and Surgical Advancements in Pancreatic Cancer towards Improved Outcomes in Pancreatic Cancer Surgery, Breakthrough, and Novel Findings. I'm Margaret Tempero, a medical oncologist from UCSF, and I'll let my co-chair introduce himself.
Okay, thank you. I'm Kim Zhang from Nanjing, China. And let's begin with our first speaker. The first speaker will be Wenming Wu. Wenming Wu is the Vice President of Peking Union Medical University Medical College Hospital. Wenming Wu is leading pancreatic surgeon and academic leader at Peking Union Medical College Hospital in China. And his topic is current status and a view of AI in pancreatic surgery, one step beyond recognition. Welcome.
Thank you. Thank you for the chair for the introduction. Thank you again for Dr. Berlin and my close friend Ashok and Min Li for the invitation to this reunion. I still think it's a reunion of each year annual meeting from about half the earth we fly from China to gathering here. So today I would like to talk about a continuously talk from last year. Last year in Maui Island, I have a similar talk about the AI in pancreas surgery. So today I would like to talk about one step beyond recognition. This picture I have shown last year about the AI is marching into all aspects of healthcare. But for today's topic, I would like to show from 2017, the face recognition, and 2018, the goals and the tools identification come into use in the clinical. And last year, for the health scenario, the real-time AI surgical assistance comes into the truth. So I want to make an example. If you are a young surgeon coming to the OR for the first time, it's very hard for you to identify what the anatomy structure of these vessels. I give some hints about the CHA or even left renal vein. So you can speak out it's SV, SMV, even MMA. But it's for a young surgeon, it's a good thing to answer the questions. But if we upgrade the question, what is the very small vessels? What these structures are? Even though have known what is CVD or SMV, but maybe you cannot speak out is posterior superior PDA or even a PI PDA. It's always for a very senior pancreatic doctors can answer the question because you have so few situation you can identify the vessels. So this is the growth of a surgeon. But if we think about how machine can learn this, we can divide into several steps to exposure, show, or recognize, even the decision making. Also, we have a lot of manipulate of the surgeons. So I think for the surgical recognition, not even for human being, but also for machine learning, we have a lot of elements. So the first is the human body structure. So machine or human must identify the structure. And then the surgical tools, instrument, gauze, system parts, and also we have to know what about the surgical event, such as bleeding, the movement of a human, such as cut, dissection, and the suture. We call it basic element. Basic element. We have to let the machine know what is basic element. I want to make 3 examples from our own work. The first one is SMV PV axis recognition. We collect over 50 videos of laparoscopic pancreatic surgery, and we annotate over 50,000 frames. We use 5 models of AI technique to detect and HR, NET, FCN, is the best performance. And also we get significantly boosted the model's efficacy. So we can see this model can achieve real-time recognition. We use a NVIDIA A100 GPU environment. We can see the left video show in the situation of LDP, we can see the square is very small and the margin is not very clear. But if we use a mixed model with LDP and LPD together, we can get a beautiful view. And also, this is a real-time demonstration in our hospital. This is not very clear, but you can see the right screen. You will see a purple line. A purple line mark the SM way and the P way. So we do this in the first time in pancreatic surgery for the important vessel, because each pancreatic surgeon have to know the SM way and the P way when he do the pancreatic surgery. And it's the first type of AI vein recognition in pancreatic surgery. This is the first example. The second one would be the surgical tool tip recognition. The structure and then the instruments. We use multi-surgical scenario and a multiple center training and validation data set to improve the sample size and improve the precision and recall rate. You can see all the instrument into the human body. And this paper just published last month. The third example is intra-operational bleeding detection. We use over 25 videos and get nearly 12,000 bleeding related videos frames. We use two kind of algorithm. The first one was RGB, and the second one is RGB plus optimal flow. And we found that the RGB plus optimal flow get more performance. And we can see this is a small bleeding. You can see the green square to identify where it's a little bit bleeding. Oh, sorry. But for the, I'm not sure. Can it play automatically? Oh, okay, that's all. But for the big bleeding, you can see not the square, but a point where the blood vessel is bleeding. So these three examples show what is recognition. But can AI really understand what we are doing? We have a structure, instrument, and even surgical events known by the, I said, basic element. But what the AI can know what we are doing and we are want to do. So the other research field is face recognition or face identification to promote understanding. Just like our human being, we consist of the ATGC, that's an encoding system to our whole body, the protein, our fat muscles. So we can divide into the procedures, surgical procedures, into a lot of phases. That phases that the machine learn what we have thought about the procedure. So we can see these two studies, 2020 and 2022, from two Japanese teams. They have great works about the colorectal surgery and the esophageal surgery. They divide all the video into at least 9 phases to let the machine know what we think and what we have done during the surgery. And also in 2023, there's a group from Hong Kong and also from Columbia University. They use ESD and hernia surgery as the field to divide them as several phases to detect what is the prediction truth and the ground truth, and is there have any difference between the two parts. And also we can see it's a little bit difficult for surgery to do the pancreatic surgery because it's the the pore of the coral. So that we see the WIPA procedure. This is a study from China. They use 27 video to make analysis, and we can see it's a pretty good job. They divided into the phases into 13 groups. Actually, before, for the most difficult surgeries such as colorectal surgery, they only have 9 phases. But for the pancreas surgery, at least 13 phases, and to know what the performance of a human being of a machine. So recognition to basic element and also the face recognition. But what we should take a step beyond the recognition, I think, at these 3 things. The first one is data sharing. We can see data sharing, data preparation, and labeling is a very time cost, a very hard work and money-consuming process. But until now, just some very small database included, but all of this is only in cholecystectomy, not pancreas surgery. So I think it's necessary to expanding the data set. How we should do so first we have to increase the size and amount of clinical centers, including different surgical groups, teams to the data set. And the different surgeons have different routine, their habit. And also cross-training and validating is critical for the robustness of the AI model. And also in these years, we have several advanced techniques about semi-automated labeling technique. We only to label 1 second or 2 seconds, and we get 100 seconds from the AI technique. And we are dedicating for the data sharing too. We are currently conducting a serious work. We share the data. From this picture, we can see we get the video from the surgeons, and then we have a data anonymization, and then we have a short video. Then we take up all the frames. Sometimes the frames is over 10,000 frames. And then we annotate all the points, times we want to have, and make sure by the expert review. So this is a data sharing in small hands. We have old Chinese words. Many hands make light work. So we have a lot of, woods. Different people get different kind of woods branches, but they have the same fire. So this is I think data sharing. The second would be this year we have last year we see two very impressive studies. The first one from the Stanford University, they use the ISRTH technique to this model achieve 100% success rate in 8 peak models. And the approach improve the policy ability to recover from the suboptimal states. This work is astonishing. That make a great step of autonomous surgical system. The other one is from Hong Kong. This is the series published paper from 2023. The team from Chinese University of Hong Kong, they introduced an open source surgical embodied intelligence. So we can train the Da Vinci system. It's a platform to do the same thing with the human hands. So in both ex and intra vivo, in vivo experiment, they got success. This picture video show 2 series. The left one from the Johns Hopkins, they achieved automated suture and tying earlier in 2023. The right one is a Chinese research team last year. They got also achieved a suture tying, and we can see the tissue pulling, tying, and the needle passing automatically by the machine. And so we can see in-body robot and intelligence, artificial intelligence, if we plus AI plus robotic embodied movement, we can get like human being, where we have learned the knowledge, the balance of the muscle memory, and also the movement and action. And the last thing, I think the next step would be AI assistant improve the safety. That I see the Tesla only get a 10 time elevation compared with Americans average for the safety. And also AI and the human, what is better? I think is not replacement, but enhancement. AI plus human can get bigger than AI even to human. We can see we have we only can use our eyes on one point, but the cameras can a lot of focusing, and also the nerve of a human being of neuron and the nerve system only have a 200 300 milliseconds, but for the machine the reflection is really short. But we have a responsibility, we have a patient caring, and also we have individual treatment from human beings. So that would be AI assistant surgery may be the solution. So the last one will be, we see several years ago, there's a very famous Hollywood movie, Alita. I love the movie very much. We can see there is a automatic surgery during in the film. So what the future direction? First step is we need a mechanized imitation, and the second would be identify items and the structures to achieve a level that is even beyond the human level. And the third step is to understand the surgical process to know the face recognition and the steps from a holistic perspective. And the last one, I think not the least, innovation and improved surgical method. So that's all. Thank you very much.
So thank you. Because we will have a discussion together at the end of this session. So thank you for your impressive presentation.
Thank you very much. The next lecture is the future of pancreatic cancer surgery. Dr. Nick Zyromsky, if I didn't butcher that, I'm not sure, from Indiana University.
Well, thank you very much for the kind invitation. And my task is to discuss the future of pancreatic cancer surgery. I have no financial disclosure. I'm not a soothsayer, and I can't say I've ever used that word in an academic talk before. But I do disclose that I will give you this view from the context of 21 years working at Indiana University, where we have a very high pancreas surgery volume, supported by a tremendous team of gastroenterologists, medical oncologists, and we approach pancreatic cancer truly with a multidisciplinary method. So what does the future hold? I'll touch on a few of these points. It's good to give us a little bit of perspective. Where did we come from and where are we now, particularly related to pancreatic head surgery, the pancreatoduodenectomy or Whipple operation, which is discrete from a distal pancreatectomy or left pancreatectomy. I'm going to speak a little more in depth about patient selection, particularly relative to tumor biology. And then, of course, you can't speak about the future of pancreatic cancer surgery without talking about tumor biology. And I'm sorry, about the robot. And as Professor Wu just showed us, I think the robot may be ready to put us out of a job here in a year or two. I'm not going to talk about whether or not we should resect liver metastases or how we can optimize surgical technique. I think those are both topics for that are important, but beyond the scope of this time frame. So pancreatoduodenectomy was reported first actually in 1898, over 125 years ago, by an Italian, Alessandro Codavia. And Dr. Codavia's patient did not survive very long after surgery, but this was the first episode of pancreatoduodenectomy. A number of other surgeons have done pancreatic head resection, including Walter Kausch in Germany, but Alan Oldfather Whipple in the United States worked on this project in the late 1930s and 40s and was the first to report a series of pancreatoduodenectomy patients. Pancreas head resection progressed very slowly through the next several decades, and in fact, in the 1970s, in the United States anyway, several prominent surgeons, including George Kreil, called for a moratorium on this operation because the mortality was quite high, 20 to 25%. And in fact, patients undergoing palliative bypass for biliary bypass, gastric outlet obstruction did better than the patients who were getting Whipples. And then thanks largely to the work of John Howard around that same time, who reported 42 patients with no mortality in the US, pancreatic surgeons were emboldened to continue. Through the 1980s, 1990s, early 2000s, groups in the US and abroad, and I know John Tillmans is here, and his group in Liverpool advanced pancreatic surgery to where we are today, which is we're considering patients for advanced vascular resection and then, of course, minimally invasive pancreatic head resection. And so where do we stand today? In 2025, pancreas head resection is a routine operation. It's performed routinely. However, this operation is still accompanied in the best of hands with a very high morbidity, and whether we call this low mortality of 2 to 4% in the best hands, that's still a substantial mortality related to operation. The elephant in the room when we consider pancreatic cancer is that virtually every pancreatic cancer patient will recur. The problem with recurrence is due to biology. It's not due to bad surgery. It's not due to bad medicine. It's tumor biology that we understand incompletely, that chemotherapy is not terribly effective. The slide, the graph on the left of the slide, the 5-year survival rate for pancreas cancer was celebrated to be increasing to 12%. This is dramatically different from other epithelial tumors, colon cancer, breast cancer, et cetera. And you can see the median survival of pancreatic cancer in contemporary days is about a year post-resection. Again, this is a problem of metastatic disease, and I think that the major paradigm shift that many of us have understood over the past number of years is accepting the concept that pancreatic adenocarcinoma is a systemic disease when we meet the patient. If you look at this study summarizing a number of patients looking at patterns of recurrence, by and large, recurrence is with metastatic disease, either local and metastatic or metastatic only. So if we consider all of pancreatic cancer metastatic, which I believe many, if not all of us in this room do, the question arises, should we operate at all? This is a philosophical question. Marcus Aurelius, of course, the Roman Stoic philosopher. I stand as a surgeon and as a surgeon with admittedly more pragmatic view on this problem after a couple of decades of taking care of people, to say, yes, we absolutely should operate. And our role surgically is in careful patient selection, doing an oncologically appropriate, technically sound operation, providing diligent follow-up for the patient, and of course, continued investigation to understand this biology. Our goals with surgery, improving the quality of life. There is no better palliation of biliary obstruction, gastric outlet obstruction, and pain for a patient with pancreas head cancer than a pancreatoduodenectomy or Whipple operation. We cannot measure hope, but I will stand to tell you that this is incredibly important and improves patients' life and improves patients' quality of life. And yes, I did just tell you that almost all patients recur, but we do have patients with long-term survival, and that also is an important goal for pancreatoduodenectomy. So what about selection? I think about selection based on tumor factors, based on patient factors, based on surgeon factors. Tumor factors, biology is king. I think we all understand that and accept that idea. But there are also anatomical factors. A patient with a tumor on the superior mesenteric vein, superior mesenteric artery, raises the question of, do we need to resect the vascular structures? Do we need to divest the vascular structures? What about the patient factors? Patient physiology is also crucial for selection. And if a patient has a locally advanced tumor or not and receives neoadjuvant systemic chemotherapy, that substantially debilitates the patient. You can see, you don't need to be a radiologist to see the CAT scan showing dramatic steatosis of the liver. When you compare that perfusion to the spleen, this is a patient who received 6 months of FOLFIRINOX, neoadjuvant. And then what happens to that liver when we clamp the portal vein to resect the portal vein? These are ideas that we need to really categorize and think about a little more systematically. And then ultimately, what about the surgeon? What about the surgeon's experience? What about the surgeon's experience with minimally invasive surgery? Importantly, what about the surgeon's team? This is Professor Jiang's team on a recent visit to Indianapolis. They have an outstanding group, and they're supported by terrific interventional radiologists, gastroenterologists, medical oncologists. This is a team effort. And the importance of that is because when patients do have complications, we need to rescue them. And that's how we get through this problem. Selection is important because of metastatic disease. Chris Wolfgang was kind enough to lend me this slide, and I think there's another one, Chris, that you gave me later in the talk, doing my job here for me. We're understanding more and more about biology. We're able to identify more and more about tumor biology and bring this into the clinical arena. These are beautiful data showing that some circulating tumor cell phenotypes can predict recurrence and survival. And the question at this point is, how are we going to use these data to potentially select patients for surgery or no surgery or chemotherapy or personalized chemotherapy? And how do we bring that into our armamentarium? Similarly, understanding the biology of the tumor and potentially metastatic tumor. This is really beautiful, elegant work by my colleague Ashik Masood at IU, looking at spatial transcriptomic analysis of primary tumors and metastatic deposits and really focusing on the differential microenvironment, the heterogeneity between tumor and metastatic deposit. And the question again here is, how do we use this information to help us select patients? And again, potentially select patients for liver resection, potentially select patients for specific chemotherapeutic agents. Personalized medicine is coming, it's here. So gaining a better understanding of tumor biology, including the response to neoadjuvant systemic therapy, will help us optimize patient selection for surgery. So maybe the future of pancreatic surgery for cancer is not necessarily in the hands of the surgeon, but is also in the hands of the biologist and the medical oncologist. Well, I'm going to shift gears briefly. And again, we saw some really incredible work with AI and robotics, but no talk about the future would be complete without talking about minimally invasive pancreatic surgery. And again, I'm going to focus primarily on pancreatic head resection. I've been in practice for 21 years, and 2.5 years ago, I've done laparoscopy for my entire practice, and 2.5 years ago, I started doing robotic surgery for a lot of different reasons, but it is very intuitive. These are two of my kids on the right-hand side of the slide, practicing on the robotic trainer at Indiana University. And again, the image of Professor Miao Yi on the robot is here to remind me that perhaps even the most experienced surgeon can embrace minimally invasive pancreatic surgery. Here, what are the advantages of the robot? Well, the visualization for some of these anastomotics, the fine anastomoses that we do, pancreaticojejunostomy, you see in the top left corner, hepaticojejunostomy in the top right corner, the visualization is unparalleled. And I think that anybody who has seen a postoperative patient with small incisions relative to the traditional midline laparotomy that you see on the right-hand side of the screen, it's intuitive to think that maybe those patients will have a easier postoperative course. But is that really true? And I think the take-home message is that the jury is still out. Our friend and colleague Felipe Coimbra in his group in San Paulo have just put together a really nice consensus on minimally invasive pancreatic surgery for cancer. They gathered 52 expert pancreatic surgeons. The median experience in this group is 22 years. They looked at the last decade of minimally invasive pancreas cancer papers, screened nearly 800 papers, and included 111 into a rigorous Delphi process. These data are under review. They're not published yet, but they should be out shortly in the journal HPB. For a left pancreatectomy, distal pancreatectomy for cancer, minimally invasive surgery, laparoscopy, and robotics is comparable to open surgery with the ability to achieve R0 resection, the lymph node yield, the lymph node harvest, And it may offer an advantage relative to length of stay and estimated blood loss. There are two strong prospective randomized studies. One found improved and one found equivalent functional recovery. And so the take-home message is that high-level evidence exists for short-term outcomes, but longer-term data are important. And what about pancreatic head resection? Again, a very different beast than a left pancreatectomy. You can just take a look at these two forest plots and see for yourself that the data are a lot more neutral. The top graph looks at morbidity, the bottom graph looks at mortality. And again, the evidence for minimally invasive pancreatoduodenectomy supports the idea that this is safe and effective alternative to open pancreatoduodenectomy in well-selected patients at high volume centers with established expertise. The outcomes obviously depend on surgeon experience and institutional volume because this is a very steep learning curve. And again, less experienced centers may not demonstrate benefits. So the jury is out, I believe, in my heart, in my anecdotal experience, as well as the experience nationally and internationally. So what are the questions for the future? Again, can we help select patients? Can we identify patients with the best biology to submit to them, to subject them to a major operation with the highest chance of interrupting the natural history of this tumor? What is the role of multi-omics in this? That's a very exciting question. What is the role of minimally invasive pancreatic head resection? Again, I did not touch on the liver mets or optimizing surgical technique, but these are other ideas in my mind anyway that are important. So I thank you for your attention, and I'm happy to discuss this further with anybody. This is my contact information. Thanks.
Let's move next speaker. Our next speaker will be Shen Baixue from Renji Hospital, Shanghai, Jiao Tong University, China. And he will talk about a new development in pancreatic cancer therapy. Please.
Okay, thank you for introduction, Professor Jiang. And good morning, distinguished experts and professors. My name is Shen Baixue, and I come from Renji Hospital, Shanghai, China. And originally, this presentation is to be delivered by my supervisor, Professor Liu Wang. However, due to his expired visa, he could not attend this meeting. So it is a great honor for me to be here to give this presentation on behalf of him. And the topic I will talk about today is the new development in pancreatic cancer therapy. Sorry. So, thank you. So as we all know, the pancreatic cancer is described as the king of cancers, and the global and Chinese incidence and mortality rates were rising year by year. And we can see that in 2022, the pancreatic cancer, the new cases of pancreatic cancer in China is approaching almost a quarter of the global new cases. So developing new drugs and improving clinical trial success are crucial to enhancing the pancreatic cancer survival. And about 6 years ago, my supervisor, Professor Liu Wang, has led a real-world study of advanced pancreatic cancer management in China. And this is the largest real-world data platform of advanced pancreatic cancer in China, with 50 hospitals participation and including 27,000 patient cases with 200 million data records. And we can see that the pathological diagnosis rate and the genomic testing rate is still not very high. And the first-line median PFS of patients reported in this real-world study is notably lower than which is reported in the clinical trial and single-center data. So the precision diagnosis and treatment of pancreatic cancer is still needed to be improved in the future. And this slide shows the evolution of pancreatic cancer drug therapies, mainly including the advanced stage systemic therapy and adjuvant therapy. And we can see the number of successful clinical trials recently has been increasing rapidly. And from the summary of the historically successful clinical trials, first line for the metastatic pancreatic cancer, and we can see that the longest median overall survival is about 11.1 months, so which is still needed to be improved future. And the first part I will talk about today is the liposomal irinotecan, now establishing its importance in pancreatic cancer chemotherapy. And liposomal irinotecan, as a novel formulation of the traditional chemotherapy drug, has achieved remarkable results in recent years. And as early as 2016, the Napoli-1 study has achieved success. So we can see that compared to the patients who achieved the placebo plus 5-FU and ARV, the patients who achieved nanoliposomal irinotecan plus 5-FU ARV could achieve more benefits in the median OS and median PFS. And so this regimen has been proved the successfully second-line treatment for advanced pancreatic cancer patients, and which also lay the foundation for the future research. And at the 2023 ASCO annual meeting, the results of Napoli-3 study has been reported. And we can see that at the first-line therapy, NALIRIFOX regimen has significantly improved approximately 2 months in both median overall survival and median PFS for patients compared to those who achieved the GEM plus NAP regimen. And based on the results of the Napoli-3, the NALIRIFOX regimen has been recommended as the first-line treatment for advanced pancreatic cancer in the ACCN guideline. And since that, the Napoli-1 study has not included the Chinese patients, and at the 2022 ESMO annual meeting, the Professor Liu Wang has reported the results of phase 3, a Chinese phase 3 trial. And we can see that the patients who achieve the treatment of the Chinese liposomal irinotecan plus 5-FU and ARV could achieve more benefit from this regimen with the significant improvement in the median OS and median PFS. So overall, the liposomal irinotecan, the benefit brought by it is undoubtedly one of the most important advances in pancreatic cancer chemotherapy, and we look forward to more favorable results in the future. And the next topic I want to talk about is the targeting KRAS, the most promising precision therapy for pancreatic cancer. And as we all know, the KRAS is the most frequently mutant genes in pancreatic cancer, reaching about 90% in Western populations. And in a previous study, our team have identified the genetic profiling of several advanced pancreatic cancer patients in China. And we found that the KRAS mutation the frequency of KRAS mutation in China is about 83%, which is slightly lower than those in the Western populations. So how to bring benefit for these KRAS wild-type pancreatic cancer patients has been a question to be explored. And therefore, the Chinese researchers have developed a notable study. So they found that the Chinese advanced pancreatic cancer patients with wild-type KRAS could achieve more benefit from the nemotuzumab plus gemcitabine at the first-line therapy compared to those who just achieved the placebo plus gem. And we can see that the median overall survival was 10.9 months in the Nemo plus gem group, and the median PFS was about 4.2 months, which both were significantly higher than those in the placebo plus gem. And although this regimen has been successfully recommended in the Chinese guidelines as the first-line therapy treatment for advanced pancreatic cancer patients with the wild-type KRAS. And the KRAS mutation has so much subtypes. The KRAS G12D mutation has accounted for about 40%, and while the KRAS G12C is about 2%. And in previous study, the KRAS G12C inhibitor sotorasib and adagrasib have achieved the success. And it has to be mentioned that China is also accelerating the development of KRAS G12C inhibitors, such as fludarabine, gasorasib, and glasirasib. And we can see that in previous studies that aggressive and sotorasib have demonstrated the favorable anti-tumor efficacy. However, the frequency of the KRAS G12C mutation is extremely low. So nowadays, more and more attentions have been attracted on the KRAS G12D mutation. And at the 2025 ISMO annual meeting, Professor Liu Wang has introduced the novel KRAS G12D inhibitor HRS-4642, a high affinity selective long-acting and non-covalent KRAS G12D inhibitor. And this study is aimed to evaluate the efficacy of HRS-4642 combined with gemcitabine and nab-paclitaxel in KRAS G12D mutant advanced pancreatic cancer in China. And we can look at the results, and the results are encouraging. And we can see that the ORR reached the 63.3%, and the DCR was about 93.3%. So this results demonstrating that this regimen had encouraging anti-tumor activity for the Chinese advanced pancreatic cancer patients with KRAS G12D mutation. And this is a typical case, and we can see that the lesions located at the liver and the pancreas have both shrank after the treatment. So based on the results of this clinical trial, the phase 3 trial has been initiated in the future. And overall, the targeting KRAS G12D is still a priority and warrant more exploration. And finally, I will talk about the development of the pan-RAS inhibitor. And this year, pan-RAS inhibitor MC6236 has reported its anti-tumor efficacy at the first line, second line, and combined therapy. And we also can see that the results are encouraging, and we look forward to seeing more favorable results in the future as the larger phase 3 clinical trials. And next, I will introduce two promising targets, the Claudin 18.2 and B7H3. And it has been reported that Claudin 18.2 has expressed higher over more than 60% of pancreatic cancer, which made it a potential therapeutic target. So at the 2025 ASCO annual meeting, a Chinese research team has reported the anti-tumor efficacy of a novel anti-Claudin 18.2 ADC drug, IBI343. And we can see that among the Claudin 18.2 positive expression patients, they could achieve more benefit from this treatment compared to those with negative Claudin 18.2 expression. And the ORR in positive group is 22.7%, while it's narrowed in the negative group. So, and this results demonstrated that the IBI343 may be has an encouraging and selective anti-tumor efficacy for those Claudin 18.2 positive patients. And when it comes to B7H3, it is also reported expressed very low or even undetected in the normal tissue. However, the dysregulated B7H3 expression has been detected in various kinds of malignant tumors, including pancreatic cancer. So to target B7H3, my supervisor, Professor Liu Wang, has led a phase 1 study to investigate the efficacy of a novel B7H3 targeting ADC drug, the YO201. And we can see that among 60 pancreatic cancer patients, the ORR reached the 30% and the DCR was 85%. So which means that this B7H3 targeting ADC has encouraged anti-tumor activity. And based on these results, we are about to initiate the phase 3 clinical trials, and we hope to look forward to the more favorable results from the randomized controlled trials. And finally, I want to talk about the DDR pathway therapeutic implications in pancreatic cancer. So as we all know, genomic instability is often driven by the aberrant DNA repair mechanisms. Once the HRD impairs the precise DNA repair, the genomic instability is often driven, and it is also correlated to the treatment benefit. And a previous meta-analysis has proved that the relationship has proven that the BRCA mutation a key gene of DDR signaling pathway was correlated with the platinum-based treatment efficacy. So we can see that among 85 PDAC patients with BRCA mutations, those who achieved platinum-based treatment would achieve the more significant survival benefits compared to those who achieved non-platinum-based treatment. And the classic POLO study has also verified it. And in this study, patients with the BRCA mutation could be benefited from the olaparib maintenance therapy in the median PFS. However, those with BRCA wild-type patients could not benefit from this treatment. And although there is no significant OS difference was observed in this study, and the POLO study still established first biomarker targeted regimen in pancreatic cancer. So since that, the correlation of the DDR gene mutation and the platinum-based treatment efficacy has been proved, and our team has recently focused on the DDR signaling pathway in pancreatic cancer. And we have identified DDR gene landscape in 1,080 Chinese pancreatic cancer patients. And we found that over 28% patients carry somatic DDR mutations. So in the future, how to develop a precise HRD score to predict the response to the platinum-based treatment and how to enrich the patients who could benefit from this regimen will be the focus of our research in the future. And this is several active clinical trials in our department. We will work hard to explore the therapeutic value of this target in the future. And so a brief summary that the new drug development in pancreatic cancer is rapid. And so apart from those targets with approved drugs or approved indications, several potential targets such as KRAS G12D are worth explorations. And besides several targets which is related to the immunity, metabolism, and the tumor microenvironment also deserve more attentions. So we hope that more targets will be explored in the future and finally bring benefit for the pancreatic cancer patients. And thank you for your attention.
Thank you.
Thank you. The final speaker in the session is Dr. Zhenjian Wei. What have we learned from the identification of pancreatic cancer subtypes? Dr. Wei is from the University of North Carolina.
Thank you, Dr. Burrow. Thank you for the organizers for the invitation to present here. I think it's a fitting wrap up to this meeting. Dr. Schwett had a really great summary of all the new therapies that are coming up. And I think what that means is that we have an opportunity for thinking about precision oncology approaches. And that's what this talk will really be about and how we came here. These are my disclosures. So I wanted to start a little bit at the beginning and give you a 15-minute roll run of perhaps the highlights of what we found in terms of, we and other groups have found in terms of pancreatic cancer subtypes. And I think that this is a moment to pause and really think about this paper by Eric Collison, which I think is really the first paper that had a very comprehensive study of pancreatic cancer and was the first study to really come to identify robust subtypes in pancreatic cancer. And Dr. Tempero may not remember this, but I do because I was a junior faculty when this came out. And I remember being at ASCO GI and in awe that Dr. Tempero actually had a conversation with me. But I do remember that she was very excited about what Eric Collison was doing and this paper was coming out. And this was even more exciting, I think, for this group here, because this was before the age of RNA sequencing. Eric's paper was on microarrays, so on gene expression microarrays, and he was able to really define these three subtypes based on that. So I think that I think that this was the true beginning. And so for those of us who were working along the same lines, we were thinking about what Eric found, and through collaborations across the country, we're able to really think about what perhaps would be different between normal tissue and metastatic sites and normal organ sites in terms of niches for seeding, which now we can do with spatial technology, but we couldn't really do then. And we looked at across hundreds of tumors, and because we had normal tissues, we were able to really start to think about what these subtypes meant. And with Eric's exocrine-like subtype, what we noticed was around the box, what you see is that things were actually in the green track bars are actually normal pancreas. And so that made us think, well, perhaps we're talking about mixtures here, and with the pancreas bulk tumors the way they are, that we're actually picking up pancreatic normal exocrine pancreas. That led us to start thinking about, well, if we were doing these bulk gene expression analysis, how can we then digitally separate the tissues before the age of single cell RNA sequencing and spatial? So that led us to a computational method that I won't talk about, but what it did lead us to is a very agnostic way of looking at tumor-specific signals. And when we started looking at tumor-specific signals, we also found immune-specific signals and fibroblast-specific signals, which I won't talk about, but I think you can hear more about tomorrow. And what we found were two neoplastic compartments. One of them we called classical in homage to Dr. Collison's classical subtype. And the other one we called basal because it had a really incredibly high similarity to basal breast cancer, triple negative breast cancer, as well as basal bladder cancer. And this has been now revalidated consistently by us and other groups over time. So we're very comfortable that these are two intrinsic subtypes. Now, the field of subtyping has exploded over the last 10 years. We are not the only two groups that have done this. There are many groups that have looked at mixtures in terms of the tumor microenvironment and the tumor subtypes. And all of them, I think, have validity. We just have to understand a little bit about what they're actually looking at. And my one caveat is that perhaps we made the field a little bit more confusing by calling everything the same. But depending on what system you used, we're probably only, on a single sample basis, we're probably only agreeing about 50 to 60% of the time. So you do have to be careful which system you're using. So I am going to talk about the Moffitt subtypes, the basal-like and classical subtypes, largely because while they were important prognosis, the real question was whether they were going to be important in terms of therapy response. And we were able to collaborate with the Princess Margaret group and Steve Gallinger and Jennifer Knox at the time and look at their early data of the first 50 patients treated with FOLFIRINOX. And what we immediately found was that patients with basal orange, so basal will always be an orange, were very resistant to FOLFIRINOX chemotherapy. And that was really quite dramatic. So we went to a second clinical trial that was ending at the time, which was also a FOLFIRINOX-based clinical trial that was led by David Linehan and Andrew Wong-Gilliam at Washington University, St. Louis, and also saw the same thing, albeit in a very smaller set of patients, where basal patients were much less responsive to any FOLFIRINOX-based therapy. Since then, the COMPASS group with Granny O'Kane's paper have, I think this was over 100 patients now in the COMPASS trial, where they again reconfirmed that basal patients were more resistant to FOLFIRINOX. And I think that this was the icing on the cake with the PASO-1 trial that was just published this year by Jennifer Knox. Again, what they found was in a randomized setting between Gem/Abraxane and FOLFIRINOX first line, basal-like patients were much less responsive to FOLFIRINOX therapy. And so that brings us to the hypothesis, which we've been thinking about a lot, which is while all trials are showing therapeutic equipoise for FOLFIRINOX and Gem/Abraxane, and you heard Dr. Schwez's discussion of some of the chemotherapy regimens, is there really therapeutic equipoise when we throw in the context of subtyping? So how can we actually answer this question, right? If we were asking, if we had this hypothesis, this came to be a barrier for us. We couldn't actually use these subtypes in clinical trials unless you created an integral marker, and we needed a single sample classifier. So Dr. Naeem Rashid at the University of North Carolina, who was an assistant professor at the time, created a single sample classifier. It's very simplistic, and I can talk about it offline, but I'm going to move on because I'm halfway through my time. But suffice it to say that this classifier is only 16 genes. It can work on any platform that's agnostic, so like poly-A tailing RNA sequencing, nanostring. I will say that the new RNA exome platforms that are now commercially available, I would caution using this. This was not developed on those platforms. Those were not present at the time. We think that our algorithm actually does not work well on those platforms or needs to be revalidated. However, NanoString is a very agnostic platform, so we were easily able to convert it to NanoString, which is available in our can be a laboratory developed test. So it was CLIA validated. We worked with a UNC group in pathology to do this and found high concordance between NanoString and traditional poly-A sequencing. And so now we have a marker that can be used in clinical trials, and this clinical trial is going on. This was first initiated by Susan Tsai, who's now at OSG when she was at MCW, and currently being led by the MCW team of Kathleen Christians, Doug Evans, and Erkut Borazanski at Honor Health. And what this trial is doing is it's asking the question if we can biopsy a patient, EUS-guided FNA core, put in archival, put in FFPE, cytology substantiated tumor cells get sent to UNC Health System for the CLIA approved lab. The turnaround time is less than 5 business days. They will report out whether a patient is a basal or classical subtype. Basal subtype patients are going to Gem/Abraxane based on our hypothesis, and classical subtype patients are going to FOLFIRINOX. So they are about, I think, halfway to a third of the way through enrollment in this trial. All right, so I wanted to step back a little bit and talk about mixtures. And so one thing that I think those of you who follow the field know is that it's very clear that tumors are mixtures, right? We went through bulk mixtures, but even within the tumor intrinsic compartment, there's subtype mixtures. And how does this relate to therapy response? Because this is a clinical session, I am not going to talk about subtype plasticity, which is incredibly important. There's a lot of elegant preclinical studies that suggest that these subtypes can switch, but we are not going to talk about this today. Instead, I want to highlight Fayez Nada's work out of Princess Margaret. His work was the first real comprehensive study using single-cell RNA sequencing in pancreatic cancer. And what he found was both on a bulk level and on a single-cell level, he split our basal and classical into 2 groups, and that may actually be true very much biologically, but clinically, there are probably 2 larger groups that we can think about in terms of clinical response. But the last graph, the bar graph on the bottom, shows you the mixtures, okay? So it shows you how within each single cell cluster, you can, or even sometimes within a single cell, you can have both basal gene expression and classical gene expression. So what does that mean? So we can actually see this on a bulk level, and this was hidden a little bit when we first published our paper, but we can actually look at the fraction of basalness or the fraction of basal expression in a tumor. And if you pay attention to the box plot in the middle with the orange and the basal-like, what you can see is a direct correlation between how basal a tumor is and how resistant it's going to be to FOLFIRINOX. So the more basal content you have in your tumor, the more resistant you are to FOLFIRINOX therapy. And actually, Fayez Nada's paper showed this. She showed hints of this in his paper. So in the panel on the left side, what he's showing is at diagnostic, he had a classical tumor. They had a classical tumor in the pancreas. At progression, this is untreated. The tumor was basal in the liver, and the basal subtype is more frequent in liver metastases. Fayez has done a lot of work on ploidy. He has some recent papers on ploidy as well. But his point in this figure was that at progression, there was tetraploidy that the tumor had evolved into that explains the basalness of the tumor. And on the right is a patient that was actually treated. I can't remember if it was treated with FOLFIRINOX. Actually, it was treated with Gem/Abraxane. And so we had a classical had a basal tumor that was treated with Abraxane, and when you look at the ploidy, you actually have lost one of the clones, and that has reverted back to classical. And so I think whether it's plastic or whether we're selecting and killing off certain subpopulations of these subtypes, I think it remains to be seen. And so in the last 3 minutes of the talk, I wanted to shed some light on new therapeutic approaches. And so I think one of the big questions for us has been, can subtypes actually shed light on biology, and can it shed light on new vulnerabilities for pancreatic cancer? And in the talk this morning, I think with Dr. Lee's talk in the first abstract session, he talked about proteomics. So this is now we're moving to proteomics. So we looked at the kinome, so kinases in these subtypes, and found that the kinome of the basal and the classical subtypes are incredibly distinct, with receptor tyrosine kinase emphasized and enriched in the basal subtype tumors, and now you're thinking targeted therapies. Classical tumors have really understudied kinases and serine threonine kinases that we're still understanding. So EGFR was one of the receptor tyrosine kinases that we saw highly enriched in basal subtype tumors. And we went back to all of these negative trials with EGFR inhibitors and asked the question, if we knew what the subtype of these patients were, would basal patients benefit from EGFR inhibitors? And I think so this is the ACCEPT trial. It's a randomized 2-to-1 trial of afatinib versus gemcitabine in Munich, Germany. And this was actually an introduction made by Eric Collison. But what we found when we sequenced their tumors were, if you're a basal in the warm colors in orange and yellow, you actually benefited. You had a doubling of survival if you had an EGFR inhibitor. And that was actually true of a second trial that they also were kind enough to share with us, a rash trial with gemcitabine and erlotinib. And again, if you were a basal, you actually had a lower hazard ratio with EGFR inhibitor treatment, whereas with classical patients, there was no difference. And so now this has provided the preliminary data and the rationale now for a trial that's open now at UNC that we're hoping to open up at more centers, looking at, again, selecting patients by subtype. So if you have a basal subtype, you will get gemnab, paclitaxel, or erlotinib, and classical patients will go to standard of care. I think that the kinomes are real, the distinct kinomes. I think that this partially explains what a lot of the field is seeing with RAS inhibitors that you just hear Dr. Shred talk about. And so Anupriya Singhal in Tomas Tamella's lab and Julian Dilley and Andy Aguirre's lab published these papers back-to-back last year on the G12C inhibitor that you also heard about in the last talk. What's really interesting about this is when they looked at the tumors on a single cell level, what they found was that the basal population was being selectively killed by these RAS inhibitors. So you can see why that would make sense. I didn't show you in the volcano plot, but there was also a lot of MAP kinase genes, MAP kinases in the basal kinome. And so one could hypothesize that RAS inhibitors may actually be a lot more beneficial in basal tumors where it's more aggressive and we have a lot of resistance. So what have we learned? So what are the answers? I don't have all the answers, but I think that it's clear that subtypes are associated with treatment response. They do have distinct biology. I think from a clinical perspective, we need to think about whether these subtypes are switching, as we see in a lot of the preclinical mouse models and the organoid models, or whether or not our treatments are selectively influencing and killing one of these subpopulations, because that also gives us opportunity for new combinations to think about. And so overall, I think that now we are able to think about more tailored approaches for pancreatic cancer. Thank you. And lots of collaborators over the years have really helped us with the study. We really couldn't have done this without people across the US as well as abroad. Thank you.
Thank you very much. We got a late start, and I realize that there's a lunch waiting out there for you, but if we could take about 10 minutes for questions, I think it'd be great.
Yeah, thank you all for the wonderful talks. I have the question for the Dr. Ye.
So do you think it's kind of oversimplified, just classify the pancreatic ductal carcinoma into just two subtypes? Because on histology level, we see quite a heterogeneous, histology. We classify the pancreatic ductal carcinoma into almost 10 different subtypes. But right now, the molecules seem to converge just two subtypes, basal-like or conventional. So what do you think, for the future? Should we go with the molecular? Should we go with the histology subtype?
So I think you have a great point. So we are often criticized for lumping things into two groups, and I think hidden behind that is the recognition that there is a continuum. Now, very simplified, basal tumors tend to be more poorly differentiated, classical tumors tend to be more well differentiated, and so that really aligns with what you're seeing histologically. I think that when you call different histological subtypes, you're also looking at the tumor microenvironment, and these are really tumor intrinsic subtypes. And I think that many groups are looking at the tumor microenvironment. We actually have a paper that we're hoping will be accepted soon with fibroblast subtypes as well. And I think what you see with even some of the schemas that I presented already from other groups, like with Puleo and some other groups, that the tumor microenvironment, there's an interplay, and we can appreciate that now with a lot of the spatial transcriptomics studies that came out of Indiana as well as MD Anderson very recently, that there's interplay between these subtypes, if you still accept the subtypes, with the tumor microenvironment. So there's lots of different combinations. I think the bottom line is what is going to be important in terms of how we direct therapy, right? And so I think that we need to be constantly iterating this and looking at this within trials, within protocols. I will suggest to you that the subtypes may be important differently. The tumor and tumor microenvironment subtypes may be important differently depending on the drug that you're using, right? So for instance, RAS is maybe much more effective in basal, whereas FOLFIRINOX doesn't work, which would be an exaggeration.
Thank you. I have a second question to you. Is you mentioned that use the GATA6, and there are also some study report the CK17 for the basal type cancer. I just wonder how reliable of those markers are based on your molecular studies.
So I have the answer to that from our own hands. It's less than 50%. So the IHC markers and the ISH markers alone are not sufficient. And we suspect it's because there's a continuum and they're just not enough to capture it. We actually have a paper that we haven't submitted yet that looked at about 150 tumors and matched it with GATA6 IHC, and not keratin 17, but keratin 5 IHC as well. And it's very, keratin 5 actually does a little better, but GATA6 is really not very good.
Thank you.
Hi, Minoti Apte from Sydney. Thank you for very nice talks, all of them. Dr. Ye touched upon the tumor microenvironment, which is what I was going to get into, because this set of talks did not include anything about the tumor stromal interactions. And I think, just as a comment, I think sure it is good to focus on how the cancer cells are responding to therapy, but I think combination of chemotherapeutic agents with selected targeted tumor stromal interaction therapeutics is probably the way forward. I'd like to hear comments from everyone, and even in the surgical realm, if that the amount of stroma defines what sort of surgery you might do or how you might treat in the adjuvant setting.
I can just say that I agree, and I think it's really important to select what stromal modulating agents you're going to use. I think the field is really close.
Yeah, I can just also comment that at Dana-Farber, Brian Wolpin's group has been looking at tumor microenvironment as what happens as consequence to multi-agent chemotherapy.
The surgeons agree. I think it's really important to look at the tumors as heterogeneous, and again, take this with a grain of salt from a non-biologist, but to look at the tumor response to therapy. And I'm really intrigued and interested in thoughts from the panel, particularly about the idea of heterogeneity of the tumors and selection of the tumor versus real plasticity. You know, how much of this is really tumor evolution versus cellular selection?
Yeah, I'm actually not sure that I can answer that. There are many basic scientists that are much have more elegant studies, but I can say that it's probably a combination of both. I suspect that there are extremes that aren't plastic that you cannot push in one direction or the other. But there's a mixture, that sort of middle portion, those hybrid tumors that you see on the molecular studies that actually can be pushed one way or the other. And so with epigenetic inhibitors that are coming out and other approaches, I think there's also an opportunity there to think about, can we shift things or reselect things to a tumor that's actually more treatable, right? Either by surgery or by chemotherapy or by targeted therapies. So I think that we can think about it very holistically now.
I guess this is kind of a little of my question, and so you kind of stole my thunder there. But my name is Atur Singh, University of Pittsburgh Medical Center pathologist, and I think that one of the things that would have been nice to understand a little more is the neoadjuvant setting, especially with the surgeons involved in this area. Are we getting to the point where we can utilize any subtype, whether it be histologic, and although there's 10, there's actually 5 that are recognized by WHO. But we also know that's a dynamic process, just like the molecular setting. You can see histology vary heterogeneity. But is there something that we can act on now, or we are going to be acting on in the near future when it comes to neoadjuvant and making surgical decisions?
I think that one of the major challenges from a surgical perspective is dealing with a locally advanced tumor. And it's very challenging for us to see radiologically in a pancreas cancer a response to therapy, whether this is inflammatory changes around the vascular structures or whether it's tumor. It's hard for us to say that without taking the tumor out. And then the tension in our hands, again, I alluded to this a little bit, is how much do we affect the patient's physiology with what is generally a very toxic systemic chemotherapy before we subject them to a major operation. So yeah, I'm right with you. I think anything that we can do to codify that a little bit more specifically would be great. The other question really for our medical oncologist is, if we do short course neoadjuvant and then surgery and then look pathologically at the tumor effects, we need the medical oncology team to be willing to adjust systemic chemotherapy. And that's been a real challenge in not just our institution, but other places too.
I have one more question for Dr. Zalansky. You mentioned that the pancreas cancer is all systemic disease at the time of diagnosis. So actually, the philosophy of our institution also agree with that. But right now, it's still controversial whether to give the neoadjuvant therapy to a resectable patient. What's your recommendation on that?
Yeah, I think that's another really interesting question and hot topic. And our Indiana philosophically gives systemic neoadjuvant therapy to resectable patients in general. We're giving neoadjuvant to everybody unless they're elderly or physiologically depleted and may have a hard time getting through neoadjuvant before surgery. That would be the wild card. And the hope is, I know there's an ongoing prospective randomized trial with this right now. The hope is to figure out who will benefit most, and then sub-question is how much systemic therapy. But at this point, we're giving it to most.
I also have a question for Dr. Zalomsky. You mentioned that the selected patients may benefit from minimal invasive surgery. What's your criteria? How to select? Yeah.
I don't know. Yeah. I think that the question is really out for minimally invasive pancreatoduodenectomy. I mean, there are some world experts who do everything minimally invasively, and Brett Shepard and I were talking about this before the session. I don't, um, you can select patients with small tumors or thin patients and get good outcomes. But the real question is it better? I think actually it's better for, in our hands, larger patients, patients who may have more problems with open pancreatectomy. But I promised myself I'd do 50 and then go back and take a look and see what I think. I'm not quite at 50 after 2 years yet. Pancreas head resections. There is one more ongoing prospective trial in Europe right now looking at this too. So I think the jury is still out.
Thank you. Well, I think we'll wind it up. Enjoy the rest of your meeting. Thank you to the speakers and to all the attendees for listening.